Welcome back. Today we're tackling traumatic brain injury, or TBI. And if you think of TBI as, just something that happens in sports or maybe a one-off accident, well, the research we're digging into today paints a very different picture. We're talking about a massive global health issue. Somewhere between 50 and 60 million people are affected every single year. But here's a number that really gave us pause. Predictions suggest that almost half the world's population, nearly 50%, will have a TBI at some point in their lives. So our mission today isn't just to list stats. We're doing a deep dive into sources that argue TBI isn't just an acute injury. It's often a chronic condition constantly being shaped by a whole mix of factors. And we're focusing on one key aspect: how biological sex and societal gender impact vulnerability, reporting, recovery, and, well, the long-term outcomes.
And that distinction is absolutely critical. For, decades really, research often just lumped sex and gender together, used them interchangeably. But if you really want to understand why TBI outcomes can differ so much between men and women, we have to separate these ideas. So, just to be clear, sex refers to the biology, chromosomes, hormones, anatomy. Gender, on the other hand, that's about the social roles, the behaviors, the cultural norms, how we identify and act in society. The reason TBI can look so different is because that biology and our social lives are constantly interacting, often in really complex ways.
Okay, let's start with the basic numbers then, the epidemiology. Who's getting injured? The overall international incidence rate is around 349 per 100,000 people per year. But when you break that down by sex, the annual rate is way higher for boys and men, 388 per 100,000, compared to 195 for girls and women. That's almost double. And yeah, most of these are mild TBIs, or what most people call concussions.
Right, but that statistic, men having nearly double the incidence, that's actually the first big clue that something complex is going on. It's where we immediately hit these gender-driven reporting differences. Those numbers might not show the full picture of who's actually getting hurt.
Say more about that. Are you suggesting the actual injury rates might be closer, but men just aren't reporting as much, or?
Well, it's complicated, but reporting is a huge piece of it. You look at studies on, say, high school and college athletes. Female athletes consistently say they're more likely to report a concussion than male athletes are. And this seems directly linked to gender norms. Male athletes tend to score higher on measures like conformity to masculine norms, things like risk-taking, appearing tough. If society tells you that admitting you're hurt is weak, you're just less likely to report that concussion. And it's compounded because often the same group that scores high on those masculine norms also knows less about concussion symptoms. So they might not even realize they have a reportable injury. It's like a double barrier. This pressure to be tough, plus maybe not even recognizing the signs, both are rooted in these learned gender roles.
Okay, so men are kind of socialized to tough it out, hide injuries, maybe especially in sports. Does that pattern carry over outside of athletics? Are women generally more proactive about seeking care?
It seems so. In studies looking at the general population, not just athletes, men are often less likely to seek medical treatment for a mild TBI. On the flip side, we see women who get a TBI at work being more proactive about seeking medical advice. So yeah, these societal expectations definitely seem to be skewing the incidence numbers we see and, more importantly, affecting who gets early care.
All right, let's try and untangle this a bit. Moving from the social side to maybe the pure biology, it's obviously hard to separate sex and gender effects in humans. So what do animal models tell us? Is there a purely biological reason TBI might affect males and females differently?
That's exactly what researchers tried to find out using animal models, control the environment, look just at the biology. And the main hypothesis for a long time was pretty straightforward. Female sex hormones, estrogen and progesterone, must be neuroprotective. The thinking was they could somehow lessen the damage after an injury, maybe reduce brain swelling or improve blood flow, what we call hypoperfusion, to the injured area.
That sounds logical, a biological advantage for females, right? But you said hypothesis. I sense a but coming.
Oh, it was a big but. That's where it gets really interesting and, honestly, quite messy. While there's some evidence supporting that protective idea, other studies found completely the opposite. For example, some research showed that giving extra estrogen to female rats after a TBI actually made things worse. It seemed to interfere with their brain's energy metabolism post-injury and, in some cases, led to higher mortality rates.
Wow, okay, so the hormone that was supposed to protect them actually increased the risk in that context.
Exactly. And here's the real kicker. In those same studies, giving estrogen to male rats often seemed to be protective. So it tells us it's not simply about the hormone itself being good or bad. It's about how that hormone interacts with the specific biological context, the existing hormonal environment. the receptors in the brain of that individual animal, male or female. We see hints of this complexity even in very young animals. Studies on newborn pigs with TBI found that females had better immediate outcomes, things like better cerebral blood flow and lower intracranial pressure, meaning less dangerous swelling right after the injury. This might have been linked to higher levels of another substance, a potentially protective factor called adrenomedulin.
So at least in those very young animals, females seemed biologically a bit better equipped to handle the immediate physical trauma.
On a purely physiological level, yes. If you look across all the preclinical studies that measured those immediate physical things, swelling, bleeding, blood flow, males consistently showed more severe problems right after the injury than females did, regardless of whether they were newborns or adults.
No.
But, and this is the crucial link back to humans, those immediate physiological advantages seen in female animals didn't always reliably predict better long-term functional recovery, like behavior or cognitive abilities down the line.
Ah, okay, so that gap where the immediate biology doesn't perfectly predict the long-term outcome, that brings us right back to the complexity we see in people. Let's make that jump to the clinic. What about adult humans right after a TBI? Do we see that same trend where men have more severe injuries initially?
We often do, yes. Right after the injury in the acute phase, men frequently show greater impairment. Things like being more likely to lose consciousness, having post-traumatic amnesia, and often having higher overall injury severity scores compared to women in many studies. And there's another factor that complicates things early on, what some call the AMA factor. Men are significantly more likely than women to leave the hospital against medical advice, or AMA, after a TBI.
Why is that?
It's often linked to factors that existed before the injury, things like alcohol abuse, or if the injury happened during an assault or maybe pre-existing conditions. And leaving AMA is a major red flag for worse long-term outcomes because they miss out on critical stabilization, monitoring, and early rehab planning.
Okay, so men often present with more severe acute injuries, and they're more likely to disrupt their immediate care. But you mentioned earlier there's a big inconsistency, a point where women actually seem to fare worse.
Yes, and this is a really critical puzzle emerging from the source material. Despite that trend of men having higher acute severity, some large-scale data actually shows that women are more likely to die from a TBI than men with seemingly comparable injuries. And related to that, in studies looking at patients with severe TBI, women sometimes showed worse cerebrovascular pressure reactivity than men.
Okay, let's break that down for listeners. Cerebrovascular pressure reactivity, that's basically how well the brain's blood vessels can adapt to changes in pressure to maintain stable blood flow, right? If that's not working well, it's a bad sign.
Exactly. It's a sign the brain is struggling to regulate its own environment, which is critical after an injury. So seeing worse reactivity in women in some severe TBI groups is concerning. And it forces us to ask, why this discrepancy? Why might women sometimes have worse mortality or physiological regulation if the animal data hinted at some acute protective factors?
That really points away from simple biology, doesn't it? Or maybe it points towards how biology interacts with treatment.
Precisely. We have to ask, did men perhaps respond better to certain standard ICU interventions, like specific types of sedation or ventilation, which might have been historically optimized based on male physiology? Or are there maybe subtle anatomical differences, skull thickness, brain volume, in certain areas that make the female brain slightly more vulnerable to catastrophic outcomes after a severe impact? We don't have the definitive answer, but the data forces us to consider these possibilities. And then there's the symptom experience. In the first, say, 3 to 6 months after injury, the acute and subacute phases, women consistently report experiencing more symptoms, and more severe symptoms, especially things related to chronic stress, compared to men with similar injuries. Interestingly, these differences often seem to level out later on in the chronic phase, but that initial period seems tougher for women symptom-wise.
That difference in early symptom burden really drives home the point that TBI outcomes aren't just about the initial impact. They seem to follow what you might call a social gradient, influenced by pre-existing conditions, social roles, and maybe even how symptoms are perceived or managed. Which logically brings us to these intersecting vulnerabilities you mentioned, situations where biological sex and social gender overlap with difficult life circumstances to dramatically change TBI risk and recovery.
Yes, the sources highlight at least 4 areas where these intersections are stark and, frankly, quite devastating. The first one is the aging population. We know TBI rates are climbing in older adults, mostly because of falls. But here's the intersection. While aging makes everyone more vulnerable, women over 55 actually have significantly higher TBI-related death rates than men of the same age. And women 65 and older are more likely to have conditions like osteoporosis or other musculoskeletal issues, which directly increases their fall risk and thus their TBI risk.
And isn't there also a connection being explored between TBI in older adults and the risk of neurodegenerative diseases like Alzheimer's, which, again, disproportionately affects women? Could hormonal changes like menopause play a role there?
Absolutely. The drop in estrogen after menopause is a major focus of research, looking at brain health and resilience to injury in older women. It's a complex link. The second really critical intersection is intimate partner violence, or IPV. This is a profoundly gendered cause of TBI. Estimates suggest that somewhere between 60% and maybe even over 90% of women who survive ITV have experienced injuries to the head, face, or neck. And these are often complicated by strangulation attempts, which can cause hypoxic brain injury damage from lack of oxygen, which is different from impact TBI but just as serious.
That's horrifying. The TBI is a direct result of gender-based violence, and then that injury itself likely impacts the survivor's health, their ability to leave the situation, their long-term well-being. What about populations involved with the criminal justice system?
TBI prevalence is incredibly high in incarcerated populations.
Mm-hmm.
Some studies, particularly in male prisons, find rates approaching 100%. But the crucial sex and gender finding here is about when the injury occurred. Studies show that women in prison were significantly more likely than men to have gotten their first TBI before they became involved in criminal activity and were incarcerated. And often, that first TBI is linked to early life trauma, like physical or sexual abuse during childhood or adolescence.
Wow. So for many incarcerated women, the TBI isn't a result of criminal lifestyle, but potentially a consequence of earlier victimization that might have even contributed to the path towards incarceration. That completely reframes how we should think about support and rehabilitation.
It absolutely does. It highlights the urgent need to screen for TBI history, especially in women entering the justice system, and to understand it as a potential consequence of prior trauma. The fourth area is workplace TBI, or WR-TBI. Here, we see different patterns again. Men tend to have higher rates of severe and fatal workplace TBIs, often in jobs involving construction, machinery, or working at heights. But women's rates of mild workplace TBI are often similar to men's, or sometimes even higher.
Suggesting very different kinds of jobs and different kinds of injury mechanisms are at play based on gendered employment patterns.
Exactly. Women are disproportionately injured in workplace TBIs caused by assaults. This often happens in sectors like healthcare, social services, education jobs, where they're interacting directly with potentially volatile individuals. So while men might be injured by falls or equipment, women are more likely to be injured by other people as part of their job. The very nature of the risk is gendered.
Okay, so stepping back and looking at everything we've discussed, the reporting differences, the tricky biology, the clinical inconsistencies, these stark intersections, what's the big takeaway? It seems overwhelmingly clear that what happens after a TBI isn't just about the initial hit.
That's the core message from the sources we reviewed. The trajectory after a TBI isn't determined by that single event. It's shaped by an ongoing interplay between nature and nurture, between the biological injury and the person's life context. Their roles, resources, stressors, societal expectations, all layered on top of their sex-based biology. And the fundamental challenge this presents is that our current clinical systems, from how we try to prevent TBI, to how we diagnose it, to how we approach rehabilitation, they also lack the nuance, the precision, to really address these deep-seated sex and gender differences effectively. We desperately need more research that carefully separates these concepts and considers all these interacting factors: the mechanism of injury, hormonal status, health behaviors, socioeconomic background. Without that level of detail, we risk using one-size-fits-all approaches that just don't work optimally for everyone.
And when treatments aren't optimized, when prevention strategies miss key risk factors for certain groups, that really becomes an issue of fairness, of justice, doesn't it? We end up potentially failing significant parts of the population.
Precisely. We know broadly that health outcomes follow a social gradient, that disadvantage impacts health. And TBI recovery is clearly affected by things like societal attitudes toward disability, economic stability, family support systems. So this leaves us with a final, quite provocative thought for you, the listener. Given that health is socially patterned and TBI outcomes are influenced by societal factors as much as biology, what are the ethical, legal, and social implications if we continue using these broad-stroke TBI protocols? How do we ensure social justice in TBI care, especially for vulnerable or marginalized men and women like IPV survivors or incarcerated individuals, when the science and the systems maybe haven't fully caught up to their specific needs and experiences? That's the challenge ahead, making our approach to TBI as complex and nuanced as human lives actually are.